I'm Brett Parker. I'm an assistant professor of surgery and member of the Division of Minimally Invasive Surgery at Johns Hopkins University. I'm a general surgeon who specializes in foregut surgery and primarily based out of Sibley Memorial Hospital. I perform minimally invasive general surgery including abdominal wall hernia repairs, weight loss surgery, and treat benign gallbladder disease, but specifically related to the foregut, my practice consists primarily of primary and reoperative paraesophageal hernia repairs and anti-reflux surgery for gastroesophageal reflux disease. In appropriate patients, I'm also trained to offer magnetic sphincter augmentation with the LINX device, as well as transoral incisionless fundoplication, or TIF. I also specialize in swallowing disorders such as achalasia, as well as other GI motility disorders such as gastroparesis. Oftentimes these disease processes do not occur in solidarity, and I think it's important for surgeons to recognize where they overlap so that patients can have all of their problems addressed in the same operation and ensure they have a better quality of life after their surgery. Centralizing patient care to foregut surgeons who perform a large volume of these surgeries will improve patient outcomes. So I'd ask for physicians to refer any patient with medically refractory GERD, a paraesophageal hernia, a GI motility disorder, or any other GI complaint that they feel could be benefited by surgery. Unfortunately, many patients don't see surgeons until they've developed moderate to severe disease. But here within our division, we offer a multifaceted team for every stage of patient care, including early refluxers, and can give them a home for comprehensive treatment. I partner with referring physicians to ensure there is shared decision-making between the surgeon, the patient, and their primary doctor or gastroenterologist. Oftentimes there is more than one treatment strategy available, and this multidisciplinary approach ensures that the appropriate intervention is chosen for each patient. After my consultation, the referring physician can expect a summary of our discussion as well as my personal contact information to maintain an open line of communication for appropriate patient follow-up.